I also would like to talk a little bit about how the anatomy changes post-childbirth, and does that have anything to do with sexual function? And I guess I want to kind of also at some point soon define some of the problems, right? So I
Sure,
can think of
of
I
course.
can think of three off the top of my head, right? One would be low sexual desire or hypoactive sexual desire. One would be inability to have an orgasm, and a third would be discomfort or pain. Clearly, a big problem for women post-menopause due to vaginal atrophy. So those are three things I think we must address today. Do you think there are others that are important enough that to a non-expert audience we should also present?
Well, I think I never want the forgotten, we'll call her sister, the forgotten sister, to desire as arousal. And having women understand that, when they come to me, they're like, I no longer get turned on. And I mean, so is it about wanting?
Mm,
Is it about mental or subjective or cognitive excitement? Is it that bridge between desire, meaning thinking, and actually being in a moment and being excited? Or is it their genitals are no longer responding? And then that sometimes is uniquely or can be tied to
I
orgasmic
see.
difficulties.
Got it.
And
Okay.
I think it's really, in the field, it's an area of discussion and sometimes even controversy. But I think for women, it's hard to separate what they're asking for. Like, sometimes women come to me and they say, like, I no longer want sex, but everything works okay. Sometimes they say, like, I love this person, or I want to have sex with myself. That's not the problem, but nothing's turning on. Like, I'm not feeling anything. And learning about that for one's body and being able to articulate that. And that can be often, I think it gets commonly tied to orgasmic changes. And we could certainly discuss whether they're the same process or different.
Okay.
Childbirth, I don't know if you want to talk about that now. It is
Yeah,
a,
let's talk about it just because I
yeah,
think we've already established that there are these two enormous hormone swings, right? There's the swing on, which is, reasonably quick, and then there's the swing off, which is relatively abrupt, but as you point out, it's occurring over years, not months.
right.
Um, it's also worth mentioning that it's the estrogen and progesterone that are coming off really quickly. The testosterone is kind of coming off not as quickly. We can maybe
Correct.
come
Yeah.
back to that in a moment. So yeah, let's talk about anatomy in a minute, because I'm guessing that women have very different experiences with childbirth, and presumably a vaginal delivery is different from a C-section in terms of the impact it has on the pelvic floor. By the way, that's something we should define for people so they understand the anatomy of the pelvic floor. But anyway, yes, let's talk a little bit about how that might impact any of the elements of sexual health in a woman's life.
Yeah. So, it's not the time typically where the sexual problems that people come to me for, I'm also not a gynecologist,
Hmm.
um, kick in and stay. They tend to be, for some women, relatively transient postpartum, but it also depends on like how many kids and what age and all of that. But so let's talk about the pelvic floor for a moment, because that's where that might impact with childbirth. So the pelvic floor is kind of a mysterious concept, but if I had to give it one concept, it's the idea that it's a basket of muscles.
Hmm.
And they attach from various parts of the inner pelvis. So like, onto the pubis ramus, onto the ischial spine, onto the bones around our pelvis, internally and into the walls, and then also into the organs. And they create a basket around the uterus, around the urethra. Like, for example, there's a sling around the urethra and the anus that holds it up and also holds up the uterus. And they also provide motion during childbirth. They allow for the childbirth process. They're quite active during sexual activity. They contract and release. They help us with urination, with defecation, so forth. And it'd be easier if we had like the opportunity to show people a diagram. But I think the best way to understand it is,
We'll include diagrams
yeah,
in the show notes. So yeah,
that would be
yeah.
wonderful. The best way to understand is it's a basket of muscles that hold things up and help things move. And when they're not working properly, they can result in, for example, difficulty with urination or incontinence, or sometimes pain during sexual activity, or changes in orgasmic function. That's sort of the broadest concept. We can get into the nitty gritty of disorders. But during child, I guess you were asking about childbirth. So with pregnancy, those muscles stretch a lot.
Mm.
Things are expanding. And sometimes women will notice improvements actually in their sexual function because if they've had tight pelvic floor muscles that are causing changes in sexual response or even pain, it sometimes gets better. Sometimes with deliveries, they get stretched, they get irritated, they get torn. It's rare that any of those things I find persist unless there was really a birth trauma. That often gets confused with what happens with other things during childbirth. For example, episiotomies, lacerations, suturing, where there can be scarring, there can be inflammation around a suture line, there can be, et cetera. So I think the general process of muscle stretching during childbirth is one thing. During pregnancy, it's different. And any other related injuries or trauma during the actual birthing process of vaginal delivery is another. And the only other thing about C-section versus vaginal delivery, this could be a whole nother topic, but in general, vaginal deliveries are better for women, right?
Say more about that. I'm very ignorant of most of these topics.
I think people have this idea that they're going to preserve the size of their vaginal canal or prevent their pelvic floor muscles from stretching, et cetera. And the truth is that most of that goes back. It's not all that unusual for women to just have a transient difficulty for 4 to 6 weeks and things improve. But having surgery, an abdominal surgery, you're opening your abdominal wall, there are muscles, there's scarring. It sometimes leads to other kinds of later difficulties that people don't anticipate. And it's also safer for the mother and the baby not to have surgery, right? But again, I don't know that number. Okay. But I know that we could easily find it. Yeah. I don't have it offhand. I'm not an obstetrician. I don't deliver babies. But the biggest concern, that I hear in sexual medicine discussions is that people have this idea that it's better for their sexual health not to deliver babies vaginally. Maybe that's the most important message. And that the number of C-sections, has been going up and is alarming. And that routine scheduled C-sections to preserve sexual health, for a whole number of reasons isn't really better for women. And that might be a myth. Yeah. It'd be good to, I'm not an expert in childbirth or in delivery because I'm not an obstetrician or gynecologist, but if someone asks my opinion, I say, have your baby vaginally, and most people preserve their sexual function. That's not a peak time. The bigger problem actually is postpartum that comes up in my practice. People are breastfeeding. They're essentially like postmenopausal women, and they may experience, because their hormones are dipping way down, they're still keeping ovulation off by breastfeeding, and they're experiencing vaginal dryness, irritation, sometimes changes in sex drive, and they're not aware of the effects of breastfeeding on sexual function, on vulvovaginal changes and sexual response. And there's easy things to do for that, just like, especially the vulvar and vaginal symptoms.
Can you give me a sense of how high the FSH and LH are during breastfeeding?
You're asking, are they organically comparable to a postmenopausal woman, I guess.
Yeah, and is estradiol sufficiently low as well? I'm trying to understand how low estradiol is, how high FSH is.
I think there's so much variability because so it depends on, if you're completely breastfeeding and ovulatory, women can look postmenopausal, and that's defined as over an FSH over 35. Most women aren't fully anovulatory. Mm-hmm. They're having irregular cycles. They're ovulating intermittently. So I think the numbers are all over the board.
Interesting.
But you can have estradiols as low as 20 or 30, right? Which isn't
might as well be in menopause.
In postpartum, but it again, and everybody's HPA axis and sensitivity to lactation is a little bit different. And sometimes women aren't breastfeeding completely, right? So the correlation with how much milk they're making and whether they're ovulating isn't clear cut either. But I think what I would say is if you're breastfeeding and you're not having menses for 6 months, the likelihood that you're hormonally similar to a postmenopausal woman is higher, and that you're completely anovulatory, and that if you're having dryness and difficulty and pain and low sexual function, that you should talk to your doctor, because there are things that we would do some of the same things that we'll probably get into in a little while.
Yeah. We're going to talk about that because I guess you could make the case that if there's one thing we want listeners to take away from this program, it's that there's really no reason for any woman of any age to be struggling with vaginal dryness, regardless of how far she is into menopause or whatever. We have the technology to solve that problem all day long, right?
So there's a number of approaches, and that is the most treatable or the most manageable amongst these conditions. And the algorithm or the options for that are the most clear cut.
Yeah.
It's amazing to me. So I'm a general internist by heart. I'm a card carrying general internist, although I've gotten quite specialized in my work. And so some of my colleagues say to me, well, you're not doing procedures, you're not a gynecologist, what's the big deal? You just come, you hand them a lubricant, a moisturizer, maybe some vaginal hormones, what's the complexity of the concept or the consult? And what it comes down to is women really, really don't understand the whole thing. Like the difference, what's happening in their body, the difference between the things that we can offer them and how to put them together and use them, and then how to integrate that into their sex life. And that's what I would say, like the number one concept that I get or referral that I get is to help a woman walk through that.